Hello everyone, my name is Liliana and today I will be talking and reflecting on my role as a psychiatric mental health nurse practitioner while discussing the case of Nick, which is a 22-year-old male with schizophrenia who was admitted to the inpatient psychiatric unit for worsening psychosis. I will be reviewing his diagnosis, the movement disorders he experienced, and how we manage them and how I would support with medication adherence moving forward. So Nick is exhibiting symptoms consistent with antipsychotic induced movement disorder after starting risperidone 4 milligrams daily. His initial presentation of jaw locking, upward deviation of the eyes, and neck extension is most consistent with acute dystonia, which is a sudden involuntary contraction which often occurs within hours to days after starting or increasing a dopamine blocking medication. Research published in the Journal of Clinical Psychopharmacology notes that acute dystonia is one of the earliest and most dramatic extrapyramidal reactions to antipsychotics, Smith et al., also abbreviated as EPS. 2 days later, Nick developed severe restlessness, constant pacing, and inability to stay still. This is the most consistent with akathisia, a medication-induced movement disorder strongly associated with antipsychotic use. According to the review of the Lancet Psychiatry, akathisia often represents an internal tension and a compelling need to move. Miller et al., 2020. Medication-induced movement disorders would be clients taking antipsychotics can experience several differential movement disorders commonly known as EPS symptoms, which would include acute dystonia, akathisia, drug-induced Parkinsonism, and tardive dyskinesia. These symptoms occur due to dopamine blocking the nigrostriatal pathway. Acute dystonia involves sudden painful muscle contractions, often locking the jaw, neck, or eyes. Nick locking and upward deviations would be classic signs. His rapid improvement after receiving IM diphenhydramine 50 milligrams reflects the standard treatment used. Anticholinergic medications such as benzotropine or diphenhydramine are first-line interventions. A 2022 article in the Journal of Neurology confirms that these agents reverse dystonia by restoring the dopamine acetylcholine balance. Brown and Patel, 2022. Akathisia is characterized by intense inner restlessness, pacing, rocking, and inability to sit still. Nick marching in place and repeated standing are classic symptoms. Treatment typically would include using beta blockers, benzodiazepines if the anxiety is severe, or reducing or switching the antipsychotic medication if clinically possible. Tardive dyskinesia is a late onset, potentially irreversible disorder of movement involving involuntary facial or limb after chronic antipsychotic use. The preferred treatment is a BMAT2 inhibitor such as valbenazine or dutrabenazine, which is supported by strong evidence for reducing these symptoms. A 2023 article in CNS Drug emphasizes BMAT2 inhibitors are the first-line therapy for tardive dyskinesia and significantly include the quality of life. Risk and benefits of long-acting injectables would be maybe a strong option for Nick because since he is not adherent, it can improve the adherence and reduce the relapse rate. The benefits would include medication delivery every 2 to 8 weeks, decrease the hospitalizations, have more plasma stable levels, and improve his functioning. The risks include injection site reactions, long duration or side effects since the medication cannot get rid of in the body since it lasts longer, and then higher cost compared to oral antipsychotics. Overall, the benefits would outweigh the risk in this scenario. And then promoting medication compliance as a psychiatric mental health nurse practitioner would include building rapport and trust, including acknowledging Nick's lived experiences and psychosis, using shared decision making to empower him and his treatment choices, providing psychoeducation about schizophrenia, relapse prevention, and how medications work. I would also explore barriers as far as medication side effects, insight transportation, and the fear of the stigma, and then offering long-acting injectables options if appropriate. I would collaborate with Nick's family, especially his mother, while maintaining patient autonomy, and then reinforce small sources to build self-efficacy. Emotional intelligence would be very essential here. Part of my reflection involves recognizing my own responses, feeling relief when Nick is improved after treatment, and noticing frustration during severe agitation, and understanding how these reactions influence my care. Being aware of my triggers helps me remain calm, present, and supportive when treating patients. Thank you so much.